This is HealthCall Online, the place for extended versions of interviews you hear on our weekly radio broadcast, the HealthCall Radio Hour, now available to stations across the country in national syndication. You know, our body has more than 30,000 miles of arteries, and the vital role that play is sometimes, well, it's interrupted as the walls of these arteries get filled with junk. It's called plaque, cholesterol, and some other stuff. And occasionally that can pose a critical risk to our health. It can lead to heart attack and stroke. So if you know it's there, is there anything we can do to reduce that risk, either make that plaque safe or better yet, remove it? Some people say the answer is no, but we're going to meet a cardiologist today who has experience in a treatment that he says does, in fact, help significantly reduce your risk of heart attack and stroke. He is Dr. Eric Goulder from the Heart Attack and Stroke Prevention Center of Central Ohio in Columbus. What's wrong with how we treat heart attack and stroke today?
So I think, well, how we treat them is fine. We try and stop them, right? You get to the hospital, and we put a stent in or have you go to bypass surgery. The problem is that we are very reactive in what we do. We really in this country, we don't do much to try and keep you from having those events. Okay, so those events are those heart attacks or strokes are caused by not by the plaque in the artery. Okay, so here's what a normal artery would look like. Yeah, what we're trying to accomplish is, somebody whose artery looks like this is totally normal. The problem we get into is when your artery looks like maybe like this guy here, and you've got all this plaque in here. All that yellow stuff is plaque, and the plaque's not causing a problem until it gets to be so severe that the flow is starting to get limited, and that's a 65 to 70% blockage. But most of the heart attacks and strokes, 85% of them, are caused by blockages that are significantly less than that. And what happens is that plaque ruptures and your body tries to heal it with blood clot, just like when you cut yourself, out working in the kitchen or out in the yard or nick yourself shaving, you're going to get a scab there. And the same thing happens inside the artery. You get a blood clot in there, and if it's big enough to plug up the whole artery, that's when you have a heart attack or a stroke.
Got it. So bring that artery back up again, and let's take a look at this. So think of your artery as a garden hose, and there is an inner lining that plays a critical role. So let's talk about that. And when you say that the plaque ruptures or erupts, that's what we're talking about, right? It breaks through that inner lining?
Right. So this is a normal looking artery here. And what you see in there, all those little, I don't know if we can get it big enough for you, all those pink cells in there with the red dots, that's called the endothelium. That is the one cell thick lining layer of the artery. Right under that is this pink layer here, not the red, but the pink layer, and that's called the intima. That's where all the cholesterol builds up, and your body's response to that cholesterol building up, which is inflammation. And then there's a muscle layer, which is the red stuff, and there's an outer wall. But really, the intima is where all the bad stuff happens. Okay, and that's what
Got it.
That's what this stuff is. That's all that yellow stuff in there is all that cholesterol building up in the artery.
So my understanding is when that endothelial lining, those cells rupture, tear, break, and that plaque underneath comes into contact with the blood, your system automatically sends clotting factors, and you form that scab, that big clot in your artery.
That's right.
The risk then becomes what?
So if that clot is big enough, it can plug up the flow through the artery and cause that heart attack or stroke. Probably more commonly than that is when it ruptures, and since there's no sensory innervation inside your arteries, the outer wall out here's got sensory innervation, but not inside. And so,
which means you don't feel it, right? I mean,
exactly.
It
so
just
this can
happens,
rupture over and over again. If it's not a huge clot, your body can handle it. The wall gets remodeled and the blockage gets bigger. The opening for the blood flow gets smaller. This can go on over and over again, leading to things like vascular dementia, leading to chronic heart failure and that sort of stuff.
Got it. So the idea here is to find out, A, how much plaque do I have, and B, what's its status? Because I understand just having the plaque itself is not great, but it's not life-threatening.
That's right. So, and that's one thing that I think most of standard, if I say standard of care medicine, what I'm referring to is what I used to do for 35 years. Okay. I was a standard of care cardiologist. I did all the stuff cardiologists do. I did heart casts. We put in stents, stress tests, read echocardiograms, put in pacemakers, all that sort of stuff. The standard of care cardiology I'm describing is cardiology where you practice by guidelines directed by the American College of Cardiology, the American Heart Association. How there's guidelines for how we treat everything, how we treat a heart attack, a stroke, diabetes, high cholesterol, you know, congestive heart failure, rhythm problems, anything in cardiology. And I still do that, but we go beyond that, because what standard of care cardiology does not do very well is look to actually see if you've got arterial disease. They're going to wait until you have problems, and then they're going to say, well, let's do a stress test on you. And if your stress test is abnormal, then you're going to go on and get a heart cath and maybe, you know, standard bypass. If your stress test is normal, you're going to get a pat on the back and send on your way and say you're doing fine. And the problem with that is this blockage, you know, if you've, like I said earlier, these blockages, the milder ones, like this guy, are the ones that are usually causing the event. When you've got blockages like that, that's going to cause a stress test to be positive. A blockage has got to be.
Okay, well, let me pause that for a second. So for our radio listeners, what you're talking about there is a significant blockage where, right, just think of like that garden hose. A clog of dirt has restricted the flow of the water through that hose so, right, severely that you're not able to water the flowers. So kind, right, of the same thing in an artery, right?
And so, and just like using your water hose example, I use that all the time with my patients. A blockage has got to be 65 to 70% before it's blocking the flow of the fluid, blood in this case, enough to cause the blood flow enough to cause your stress test to be positive. So if you've got a milder blockage, it's the flow, and you know this from using a garden hose. If you cover up the opening of the hose halfway because you can't find the nozzle, the water's still going to come out and just sort of drip down, okay, shoot down slowly. When you've got to cover that opening 2/3 or 3/4 before the flow decreases, the water accelerates across your thumb and shoots out way far, right? And so that's the same thing with a stress test. If you've got a less than 65% blockage, the flow is going to be normal. And you're going to get that pat on the back, and you can come in the next day and have that heart attack. And that's why we've all heard stories of people, I just had a heart attack. I just had a stress test. You know, 2 months ago it was fine, and they dropped dead the next day. And there's lots of examples.
Yeah, absolutely. So what we want to do then is identify A, do I have plaque, and B, what's its condition? So my understanding is if this plaque is calcified, it's not so much of a risk. So what does that mean?
So when we look for plaque, we do something called a carotid intima media thickness scan. It's an ultrasound scan of the carotid arteries on either side of your neck. And we're going to actually look at the wall of the artery and see if there's evidence of arterial disease. Is the lining in the artery, in the common carotid arteries that comes up your neck, is it thicker than it should be, which means you've got cholesterol and inflammation building up? Do you have any plaque? The definition of plaque is a 1.3 millimeter area of thickening. And then if you've got plaque, what's the quality of that plaque? Is it all soft and inflamed, which means it's much more unstable because there's white blood cells in that plaque that are spewing out proteolytic enzymes that can chew on that thin lining over the plaque and make it more likely to rupture. It can be heterogeneous, which means it's a mixture. There's some healing going on, and the healing is that when we get all the inflammation out of the plaque, it's going to shrink down, it's going to scar down and calcify. And so as you get all the inflammation and all the cholesterol out of that plaque, is going to calcify and become much, much more stable. And so that's what we're looking for. We're going to look. Go ahead.
So that is the CIMT. That's the ultrasound that you did on me and on a friend to take a look at what's there. And if it's in my neck, but then I'm assuming it's everywhere.
It tends to be a diffuse process. Okay, so it tends to be everywhere. And so if we find it in your neck, most likely it's in your coronaries as well, and possibly in your abdominal aorta down to your legs, causing peripheral vascular disease, that sort of stuff. But if we don't find it in your neck, and we're really concerned about you, and you say, hey, I really want to know, I've got this family history, dad died at 45 with a heart attack, what's my risk? I said, well, let's look elsewhere. We'll look in the femoral arteries. We'll look in the abdominal aorta, and we'll do maybe even a coronary artery calcium score on you. That's another non-invasive test. The coronary artery calcium score is a CT scan of the chest, looking to see if there's calcification in the coronary arteries. If there is, that says you've got arterial disease, and we need to do something about it.
Yeah, so I've done it. A lot of people go to a hotel and have one of those calcium scores. What is that not telling me?
So what the calcium score does not, I don't, not at a hotel. Did you get a mobile carotid scan done?
I
Like,
went to what was the name of the company? Yeah, I went to a hotel room, or
okay,
and they come in and they have a team and they cycle you through and life scan, health scan,
LifeScan.
something like that.
So what LifeScan does
Yeah,
is they do ultrasound and they're doing the Doppler study again. They're looking at the flow through the artery. And so what they're going to tell you is we may see some plaque, but we're not going to tell you the nature of the plaque, but we know that the flow through the artery is fine. Don't worry about it. They're going to look at your abdominal aorta. And most important thing down there is, do you have an enlargement of the aorta down in your abdomen, which says you've got an aneurysm, which can expand further and finally rupture and cause it be life threatening. So that's a good service. It's nice to know if you've got arterial disease or not. But then the question is, what do you do about that information, right? And if you
yeah,
go to a
yeah,
standard of
exactly.
care physician, they're going to say, well, you need to be on a statin and your a cholesterol medication, maybe something for your blood pressure. That's about as far as we go in standard of care medicine about trying to prevent you from having trouble. Okay, so
Okay, but the CIMT test that you did on me, taking a look at my artery, that gives me a whole different picture, right? So you're
it
looking at the state of that plaque.
It tells me, do you have plaque? Okay, number one, do you have arterial disease? Because if you do, then we want to know, is there inflammation ongoing? And if there's inflammation ongoing, we want to know what's causing it. Because if we find all the sources of inflammation, and there's a lot of them, it's things like, obstructive sleep apnea, low vitamin D, insulin resistance, diabetes, chronic inflammatory diseases, things like rheumatoid arthritis and Sjogren's disease and that sort of stuff. All that other stuff, along with your high blood pressure and high cholesterol that everybody knows about. If we figure out what's driving your inflammation, treat all those things optimally, and we've got 6 or 8 good inflammatory markers that we follow routinely on our patients, we can say, okay, the inflammation's turned off. We're going to do your CIMT in a year and start to watch things heal. That lining is going to start to thin out a little bit, go back down towards normal. The plaque is going to shrink down a little bit maybe, but mostly it's going to develop more and more calcification and become more and more stable. And
Got it.
that's a several year process.
So the markers that you're looking for are enzymes in the blood, correct?
A couple of them are enzymes. So one of the things we look at is called myeloperoxidase. That's a enzyme produced by white blood cells. And that's often associated with a root canal lesion, half of which can be asymptomatic. So, you can have a myeloperoxidase pop up for no good reason that you're aware of. And we're going to say, well, we got to do something about that. We got to go look for the root canal lesion, fix it so the myeloperoxidase goes back down, because that enzyme also can get in the bloodstream and chew on that thin fibrous cap. We
Gotcha.
look at the other enzyme test we look at is something called LPPLA2. The brand name for it's a plaque-2 test. And this enzyme is an enzyme that travels with the LDL, the bad cholesterol particle, gets into the lining of the blood vessel, into the intima, and it's actually driving the whole arterial disease process. It's calling over the white blood cells, saying, hey, something's wrong in here. Come on in here and fix it. The white blood cells get in there. They can't really do much about the fat that's in there, the cholesterol, so they just gobble it up. They turn into what we call foam cells, and those foam cells all clump together and then become plaque. And that plaque is soft. It's inflamed because there's still white blood cells in there. They're still kicking out their enzymes that can chew on on the thin lining over it, make it much more unstable. So those are the
Gotcha.
two enzymes tests. We look at HSCRP, which is a protein that's produced by your liver when there's inflammation of the endothelium. We look at another very specific test called the microalbumin creatinine test, and all these tests are very common tests done by a lot of doctors, but not too many people who put all this together in one thing. But
Gotcha.
the microalbumin creatinine test is looking to see at your endothelium, where it's gone down to now you've got at the capillary level. So that blood vessel is just a tube of endothelium. There's no intima, there's no muscle layer, there's no outer wall. It's just endothelium. We're looking at the kidneys, and is the endothelium in your kidneys leaky enough to let a great big molecule like albumin, a protein, leak and get into the renal tubules and out into the urine? And if you do get protein in your urine, that says the endothelium's leaking and inflamed.
So you're doing a bunch of blood work to kind of identify what is my risk factor. And then also, as I move through and try to correct things, how much progress am I making?
That's right. That's
So
right.
how often am I going to have these blood tests?
So our patients are getting the blood work done quarterly, and we're keeping an eye on their lipids and the inflammatory markers we're looking for. If they have insulin resistance, we're trying to get that under control, make sure their A1C and their fasting blood sugar is getting better, as well as maybe a fasting insulin level and perhaps a repeat glucose tolerance test at a year, and make sure that we're getting that under control. Insulin resistance is a really common problem in our country. The CDC did a report about 5 or 6 years ago. They said of the 335 million people in this country, 28.5 million people have diabetes. 90% of them know it. 10%, they're going to find it out pretty soon. There's another 100 to 150 million people in this country who are insulin resistant. A third to a half of the country is insulin resistant, and 90% of them don't know it. And you don't have to, typically, if you would have asked me 20 years ago, what does somebody look like who's insulin resistant? I said, well, they're overweight. Okay, but that's not true. There's a lot of people in this world who are normal weight and they're insulin resistant. And insulin resistance means that your body is producing insulin that's not working as efficiently as it should. So your pancreas keeps producing more insulin, trying to get your blood sugar down, driving that sugar into skeletal muscle cells and internal organs like the liver. So we can use that sugar to make energy for ourselves. But that insulin is not doing the job, and so it makes more insulin and more insulin. And so insulin resistance is a state of having too much insulin in the blood. And insulin is inflammatory. It's a fat fertilizer and a plaque fertilizer. So we want to get that under control. And that's a big driver.
Yeah, I've heard that referred to as miracle grow for all bad things.
Oh
in
my
your
God,
body.
that's great.
Yeah. So let's talk about the therapy, the treatment. You're going to get my inflammation processes under control. So that means cleaning up lifestyle. If I've got bad diet and other health habits, you want to work on that.
Correct.
So stop smoking, sleep better, all of the stuff that we know fights inflammation. What next? What's after that?
So first of all, that lifestyle piece is extremely important. They've done big studies and shown that if we've got people who have 5 major points of lifestyle under control, eating a proper diet, lots of fresh fruits and vegetables, less red meat, more fish, that sort of thing. Exercising routinely, getting that 150 minutes of exercise, of moderate exercise a week in, not smoking, keeping their weight down, waist size in a man under 37.5 inches. If we do all those things, we can prevent, compared to people who are doing none of those, we can prevent 90% of the heart attacks that occur. 90%.
Whoa, 90%?
Just by lifestyle.
Wow.
I mean, imagine what we could do in this country with all the money we spend on taking care of people who have heart attacks and strokes if 90% of them went away.
Yeah.
It'd be amazing. So lifestyle's huge. And then we're going to say, okay, we need to know a little bit about your genetics for some lifestyle recommendations, because not everybody is the same. And there are some people, depending upon their genetics, who should not be on a Mediterranean style diet. There's some people who should be on a very low fat diet. Some people need to be on a little bit higher fat diet. Some people need to be avoiding gluten to some degree. And so we factor that in. And then we get all that under control. We say, okay, now we're looking back, and you're watching your carbs. Maybe you're doing intermittent fasting with your diet, so that you've got a 8 or 10 hour window when you eat during the day and the rest of the day you're not, which gives your pancreas a rest. And we do all those things. We say, okay, you're still not quite there with your insulin resistance and your cholesterol and all that stuff. So we're going to, and if you've got, okay, and then we're going to say, okay, we need to use some medications and or some supplements to get all this under control. And so we use several different supplements. Typically, if your blood pressure's up, I'm going to get that down. Okay, we want that. We want the new normal for your blood pressure is under 120/80.
Right. So
we want your blood pressure down. That 135/90, and your doctor pats you on the back and says, we'll see what you're doing next time. That doesn't fly anymore. Yeah. So we want to get your blood pressure down. We want to get your lipids down to target levels. And our lipid levels are a little bit more aggressive than standard of care, especially if I now know that you've got plaque. So if you've got plaque, now you've got arterial disease. Now my target for your LDL cholesterol is not 100, but now it's 70 or less. And in Europe, it's even lower than that. They're talking 55 to 60 for an LDL in Europe.
Wow. So the statins are going to be a part of my life, I'm assuming. Is that correct?
So maybe, because if you don't have inflammation going on, if that LP-PLA2 number is pretty good, I'm going to say, okay, we don't have to worry about the inflammation so much, which is what the statins really do. The statins are the most potent anti-inflammatory I've got for the arterial wall. So if you've got mildly elevated cholesterol and you've got no inflammation, we're going to work on diet and exercise and maybe put you on something else to get your lipids, your cholesterol down. It could be ezetimibe, Zetia, which is not nearly as potent as rosuvastatin, but doesn't have the side effects that statins do. The muscle aching and some liver toxicity. And if we see that, we just stop the statins. But we've got other ways to handle the cholesterol. The cholesterol problem is probably the easiest thing we take care of. All the rest is tougher. Yeah. The insulin resistance and the sleep apnea and all that sort of stuff.
Yeah. So what's my, if I go to my doctor, my cardiologist, my general practitioner, and say, look, I heard this guy on the radio and I'm concerned and want to know more, what are they going to say to me?
Some of them don't know anything about this. Some of them say, oh yeah, I've heard about that test, that CIMT, but we don't do it.
Why don't they do it? What's the holdup here? It wasn't difficult. It wasn't painful. It
took 20-minute ultrasound scan, no pain, no, you don't have to take anything off. I just cover up the collar of your shirt so I don't get ultrasound gel on it. I think there's a couple of problems. I think that, and it's been around for like 25 years. It's been approved by the American Heart Association back in 2012 as a safe, reliable, repeatable, non-invasive, easy test, inexpensive, and yet insurance doesn't pay for it. And insurance doesn't pay for it, I think, because there is some disagreement in the literature. Mostly it's been used for investigational studies as a surrogate for coronary disease. But there's some disagreement in the literature as to what we're going to call too thick a lining, what we're going to call plaque. That's sort of that 1.3 millimeter number that I gave you earlier that says that's plaque and 1.2 is not. That's sort of an arbitrary number. Okay, we're going to pick a number out of the air and say, okay, I want to pick a number that if I see this number, that definitely means you've got arterial disease. And we could say, well, that number is 1.0 and say you've definitely got arterial disease. But then we're going to pick a lot of people who really don't have disease. We can make it 1.5 or 2.0, and then there's no doubt about it, you've got arterial disease, but we're going to miss people who are really at risk and maybe put them in increased risk for having an event before we get to them. So, so we're going to, So
$200, I think, is what I paid. So that's, if that can give me an indication that I'm at high risk and I need to take action, seems like that's pretty affordable.
Yeah. The coronary calcium score, depending on where you're living, is pretty inexpensive as well. $50 to maybe $200, done at almost any hospital. If your doctor won't order it for you, you can probably just call the hospital and say, I want one. The CIMT, when we do it here at our office on people like who just want to come in and say, hey, I want to know where I stand, the CIMT, we send it off and get it read by a company that does nothing but read these things. They've got very specific protocols for where to read the thickness of the lining, what's going to be called plaque. They do densitometry on the blockage that's plaque and say, okay, this is all soft or it's heterogeneous or it's echogenic. And they give us a report back that says, okay, you're 50 years old, your arterial age is 70. Well, you're at high risk. Okay.
Yeah.
So, and that's based upon how thick your lining is. So we get the report back, and then I sit down with my patients. We talk about what it all means.
And then the next step after that initial conversation is tackling those lifestyle things, I'm assuming, right? Yeah.
And so there was a huge study done about, I can't remember when now, maybe about 2013, maybe. They took 10,000 healthy people, men and women, 35 to 65 years old. Nobody had high blood pressure, diabetes, or cholesterol. They did these CIMTs on everybody. Then they said, go away. We're going to get back to you in 10 years and see what's happened to you. And what they found was there were 8,000 of the 10,000 people who had totally normal arteries, no lining thickness, no plaque. What they find? The risk of this whole group, the Framingham cardiovascular risk score of this whole group of 10,000 people was 3 to 5%. And it was a youngish crowd, and that's why the risk was relatively low. But what they found was if you've got no arterial disease, nothing happens to you. Over the next 10 years, only 10 people, 0.1% went on to have an event. If we find your lining is thicker than it should be, but you don't have plaque, now the risk goes up to 8 or 9%, so it doubled or tripled, almost tripled your risk. And if we find plaque in somebody with no high blood pressure, diabetes, or cholesterol, and don't do anything about it, 40% event rate, not 3, 4, 5%, but 40% event rate. So clearly finding plaque is a huge finding because it says we got to get busy on this. Dad died at 45. You're 40 years old. You got plaque. We got to get this under control.
So here's something that's on my mind. We're hearing in the media about all these young people having heart attacks, and I don't know if it's vaccine related or not, but this thought came together. So we know that the COVID virus affects the endothelial cells, that lining of our arteries. Is it possible that we're seeing these heart attacks as a result of COVID, the infection, not the virus or the vaccination necessarily, but the infection affecting the lining of our arteries, creating a situation in which there are plaque eruptions in people that young?
Yeah, I think the word's not out on that yet, the final word, but I think that's something that's probably going to be found out over the next several years. But what I can tell you is that even before COVID, the rate of heart attacks in millennials is going way up. And if you look at the cardiovascular death rate in this country, which was climbing from 1900 to 1960, and then it started to come down. That's when the Surgeon General's report on smoking came out. People, we used to have like 75% of the country smoking. Now it's like 25%. So the rate starts coming down. About 1970, the first open heart surgery procedure was done at the Cleveland Clinic. 1982 or so, that Andreas Grunzig developed the first balloon angioplasty, and then several years later we had stents. And you can see from 1960 to about 2012 or 13, the rate keeps coming down. But then about 2012, it starts going back up again. So before COVID, the rate's going up again. And I think it's probably related to insulin resistance in our young people. I mean, there's this epidemic of obesity and diabetes in the country. And, people are insulin resistant for 10 to 15 years before they actually become diabetic. You don't feel it at all. And all that time, that insulin, that miracle grow is just beating up your arteries for 10 or 15 years.
Yeah. I always ask guys like you who've been around this for years and have seen people go through so much trauma in their lives, how do you live differently? How do you manage your health knowing what you know about this cardiac risk?
So it's really interesting. So let me tell you a real quick story. My dad was a cardiologist, and he died with horrible arterial disease in his mid-80s. My mom had both her carotids fixed in her early 70s. She had blockage on both sides. She had a little stroke before that happened. And my dad's father died of sudden cardiac death at the age of 47. So I knew I had
doomed, buddy. You've got.
So I get out of training in cardiology, and I think, well, I know everything about cardiology, right? And I check my blood work, okay, and my cholesterol is great. I was like 160. My HDL, the good cholesterol, was over 70. The bad cholesterol was under 70. I thought, I got this made. Okay, so I'm a doctor. We don't take very good care of ourselves. So, but I'm doing everything. I'm exercising and watching my diet. Some I never smoked except for those 3 cigarettes in high school when my buddy tried to get me to smoke. And about 8 or 10 years later, and I've probably gained a few pounds, I checked my lipids again. And holy mackerel, my cholesterol is over 200, my LDL is over 100, my HDL is down to like 60. I said, well, what the heck's going on? So like most cardiologists at that point, I put myself on a statin. And so I had been on a statin. I was on Lipitor at first, then Crestor. And I'd been on a statin for probably 20 or 25 years before I had my first CIMT done, which was 10 years ago. And on my CIMT, I had a very small, totally calcified plaque in the right carotid. I'm looking at this while the tech is doing it. Actually, the guy who owns the company that reads our scans was doing the scan on me. And I said, okay, that's not too bad. And then he puts the probe on my left side, and I've got about a 25% mostly soft plaque up there. And I go, what the heck? I've been on a statin forever. Well, I didn't know. Right? We don't know what we don't know. There's another bad cholesterol particle out there that they just started describing about the year 2000, and it's called lipoprotein little a. It looks just like LDL, but it's got an extra protein on the outside. It's genetically determined. Your parents curse you with this. It does not respond to lifestyle modifications. You can run 5 miles a day and be a vegan, and your LP little a is not going to come down if it's elevated. And it doesn't respond to statins. So I'd been on statins for 25 years, and that's why I had that soft plaque there. And I said, well, we got to do something about this. And there's ways to treat it, but you got to know to look for it. And so we didn't know that back when I started on my statins. So then that changed my lifestyle some too. So yeah, lifestyle.
How do I know?
Go ahead.
How do I know if I have little a?
Well, that's a great question because it's not part of the standard lipid profile. It's something, and probably because, number one, nobody knew about it 10, 15 years ago. And it's something that you should probably get checked at least once in your life. If it's normal, you never have to get it checked again. It's not going to go up out of for no good reason. But you need to ask for it if your doctor's not doing it. Say, I want to know what my LP little a is. Okay, and they can order it. It's done everywhere, so it's not a big problem, but you got to ask for it.
Okay.
And then if you've got it, then we got to treat it. So about 20% of the world's population has some degree of LP little a.
So I want to circle back again. If you are listening to this program and decide, okay, I need to know about this, how do I find this test near me? What do I search for? Who do I talk to? What do I do?
So one thing so the way I practice this preventive approach to cardiovascular disease is by doing something called the Bale-Deneen method. So one thing you can do is you can go to the Bale-Deneen website. It's BALEDONEEN, Bale-Deneen.com, and they've got a list of all their providers around, and most of them have connections to that. Or to a company that either comes in and does the scans for them, or the provider does it himself or herself. You can call a company. You can look up a company called Cardio Risk Laboratories. That's who reads our scans for us, and they can tell you, is there an office in your area? It may be a dental office, it may be a medical office that has a tech come in maybe 2 or 3 times a year and does these scans for them. And they send techs around all over the country. If you've got, if you're a physician or a dentist, you've got put 20 or 25 patients together to come in one day and get scans done. They'll send their tech out there and just do scans all day long, and you may be able to get in there. There are other companies around that do this scan as well, and I'm really not very familiar with them because I know that the gentleman who runs this company, he's got a PhD in cardiovascular epidemiology, and I trust him. He's got a software they work on. They verify everything all the time, and they're really picky about how they read their scans and stuff. And he says it takes him a year to train somebody to read scans for them. So,
wow.
So that's who I trust with it.
Well, I'm so glad we got together. I hope people are going to be curious enough to want to have that test and find out exactly what's going on with their arterial plaque and whether they need to get busy, as you said, trying to get that under control. Hey, I really appreciate it. That's Dr. Eric Goulder from the Heart Attack and Stroke Prevention Center of Central Ohio in Columbus, Ohio. Thanks for being here.
Thank you very much, Lee.